Welcome to this myelodysplastic syndrome, or MDS Phone a Friend series, where you'll have the chance to listen in on your peers discussing common clinical challenges in the management of lower-risk MDS-associated anemia. Check back frequently to tune into episodes in the series that cover topics such as diagnosis and classification of MDS and management of patients with lower-risk MDS who would benefit from an individualized approach to pharmacologic treatment. Today, Dr. Andrew Kuykendall is getting ready to see Arthur, a patient with lower-risk MDS that is ring sideroblasts negative, and he has some questions for his colleague, Dr. Aditi Shastri.
Hey, Dr. Shastri. Sorry to pull you out of clinic. Thank you, Dr. Shastri, for taking my call. I'd love to talk to you about a patient of mine.
Absolutely. What have you got, Dr. Kuykendall?
His name's Arthur. So it's an interesting guy. He's a 71-year-old. He's got a history of colon cancer, status post-chemotherapy. But really, we've been dealing with some low-risk myelodysplastic syndrome for the past 6 months, and it's got the following features. So we did a bone marrow biopsy. It showed 60% cellularity with some dyserythropoiesis and 1% blasts. Notably, he's SF3B1 wild type, TET2 and ASXL1 mutated. We did not see any ring sideroblasts. So at diagnosis, he reported symptomatic normocytic anemia. Hemoglobin was around 7.2. And he had some mild thrombocytopenia with a platelet count around 95. And really it was fatigue and shortness of breath that were kind of his main symptoms, and that was what he described as negatively impacting his quality of life. Since diagnosis, he's been getting really averaging about 3 units of red blood cells every 8 weeks, and this keeps his hemoglobin around 8. And for what it's worth, he did have a serum EPO level that was 450. So my question is really, what would be your preferred frontline approach for a patient like this?
I think that, when we navigate the landscape of what we have for low-risk MDS, we have a lot of important things to consider. Not in the least is really supportive care, right, including transfusions, antibiotics for neutropenia, etc. But I think what we have in the mix here, and essentially what we'll have to talk through, will be ESAs, imetelstat, or luspatercept. These would actually be important available options to consider for your patient. There's some other options which we can walk through as well, but in my mind, those would be much lower down the list, given that you didn't say the buzzwords for me would really be lenalidomide or IDH targeting therapy like ivosidenib, for example. And of course, time-tested hypomethylating agents, but these, of course, we reserve them most of the times for beyond the lower risk MDS stage. And as we think about our patients, and almost every patient, I will also consider allogeneic stem cell transplantation. For your patient, Arthur, I think I would actually go with luspatercept. An interesting and important drug in our era is a novel telomerase inhibitor, imetelstat, which was just approved in 2024 for the treatment of patients that actually have a higher transfusion burden. So those that require 4 or more red blood cell units over 8 weeks, and those that are now ineligible to or lost response to ESAs. So this is not really what we're saying at this point. So I don't think imetelstat would really be the best fit for Arthur. But just because this is relevant and timely, let's go ahead and look at the iMerge clinical data to further discuss this newest addition to our armamentarium. So the phase 3 iMerge data, which was recently reported, did tell us that in eligible patients with non-deletion 5q, lower risk MDS, that were transfusion dependent, relapse refractory to or ineligible to ESAs, and naive to lenalidomide or hypomethylating agents. So this was really the group of patients that was enrolled on the study. And what we found was really that imetelstat did cause a significantly higher rate of RBC transfusion independence. The primary endpoint, which was around more than equal to 8 weeks. And at EHA, which I had the pleasure of attending in Madrid recently, the preliminary overall survival analyses for the iMERGE were also presented. And here it was presented that in the imetelstat group, the 2-year overall survival rate was 78% overall, 81% in more than or equal to the 8-week transfusion independence responders, and 75% in the non-responders. In the placebo group, in comparison, the 2-year OS was about 74%. So this is very encouraging data.
Yeah, so I guess, you mentioning all this data, I mean, it's great. It's talking about ESAs and luspatercept and imetelstat. What's your thought process for choosing luspatercept as a first-line agent over an ESA for arthro?
The erythropoietin level is very important, and I think that, along with the transfusion burden that our patients have, heavily influences our choice of first-line therapy in patients with lower-risk MDS. As we know, patients do respond to ESAs, but a good majority of them also fail to respond to ESAs in the first line. And as we mentioned, these are dictated by a few things, the endogenous serum EPO level, transfusion requirements. Ring sideroblasts are also an important consideration. So the presence of ring sideroblasts may elicit a more robust response to ESAs, but this is not necessarily a requirement. And we do see this with luspatercept as well, that the ring sideroblasts do elicit a pretty robust response. So let's go over a little bit the data for luspatercept and how luspatercept came to be in the first-line setting for patients with lower-risk MDS. And so this was as a result of the phase 3 clinical trial that we call or now know as COMMANDS. So in the COMMANDS study, eligible patients that were more than or equal to 18 years of age with IPSS-R-defined low-risk MDS, with or without ring sideroblasts, less than 5% bone marrow blasts, and a serum EPO level less than 500 units per liter, and those that required RBC transfusion, so were RBC transfusion dependent, which the trial defined as 2 to 6 RBC units per and every 8 weeks for over or equal to an 8-week period prior to randomization, were enrolled on the study. These patients were also ESA naive. And the primary endpoint that was being hoped to achieve was that of RBC transfusion independence equal to or more than a 12-week period with a concurrent hemoglobin increase of 1.5 grams per deciliter. This was actually achieved by 60% of the patients in the luspatercept arm versus 34% in the epoetin alpha arm. So this was a very highly statistically significant result that we saw in the COMMANDS study. And then when we break it down and we look at the subgroup analyses, we actually found that those patients that achieved greater responses with luspatercept were SF3B1 mutated, which also overlap, with the ring sideroblast group. These were people that had a baseline serum EPO level that was less than or equal to 200 units per liter compared to the group that was slightly on the higher end, which was 200 to 500 units per liter. So what could we say, for your patient would be the benefits of going on a therapy like luspatercept? So as we said, the transfusion independence was a very important endpoint of the study. And if we see the reduction in transfusion burden, this was something which was also very significantly achieved in the luspatercept arm. And so I would say all in all, this is a really good choice in terms of first-line therapy for your patient, as a significant proportion of patients on the COMMANDS study that were treated with luspatercept achieved an improvement in the hemoglobin levels, a reduction in transfusion burden, and RBC units transfused, and they definitely had this durable RBC transfusion independence response. So if we look at, a few different more comparisons between the luspatercept arm versus the epoetin alpha, just to reiterate the point again, a greater proportion of patients with luspatercept than epoetin alpha achieved hemoglobin independence, especially in the erythroid. So this is really the big problem that your patient is facing. Which is transfusion-dependent anemia and is what a lot of R-MDS patients face in the clinic. And the luspatercept definitely led to an improvement in erythroid, neutrophil, and platelet lineages, supporting its use in frontline in patients that are ESA naive, transfusion-dependent with low-risk MDS. And so one of the things to consider when you're discussing with our patients is that for a lot of reasons, we do know that the study included ring sideroblast positive patients much more than they included ring sideroblast negative patients. And patients did respond differently depending on their ring sideroblast status. So 65% of the ring sideroblast positive patients with luspatercept achieved the primary endpoint compared to 26% on the ESA, but in the RS negative patients, a slightly more, maybe a small percentage more achieved it with ESA, so 46% versus 41%. So if we put it into the clinical context, what does this mean? I mean, the way I talk to my patients is I say, it doesn't necessarily mean that you won't respond to luspatercept. You might, because I have had responses to luspatercept for patients that are ring sideroblast negative too, but I think ESA could also be an important consideration in this population as a first-line therapy.
So, I really appreciate this information. I mean, what would you do if you kind of started on Arthur on luspatercept, but then 3 months later we didn't see any response at all? Any way to approach that?
This is a very important question, Dr. Kuykendall, and I cannot tell you how many times this also comes up. I have to reiterate that the starting dose of luspatercept is not the dose that we end on. It's really important to up-titrate the dose. So when you start at 1 mic per kg, you have to really up-titrate them through 1.3 to 1.75. And sometimes a lot of our patients will achieve their best response at the highest dose. So this is sometimes very important to keep in mind and keep up-titrating your patients if you don't see a response. And then, if you don't see a response at the maximum dose, I would say that's when you want to start making a plan for what to do next. But I wouldn't do it before they're up-titrated to the maximum dose, definitely given that the patient, of course, is tolerating it.
And what about an older drug? What about something like lenalidomide? Could this be something that would benefit patients like Arthur who don't have del(5q, but do have low-risk MDS?
This is a good question, and I will say that it definitely still in this day and age is very relevant. So, let's go over some data for lenalidomide really in the non-del(5q setting. So we'll really talk about the phase 3 study, which was the MDS 005 in the population of patients that are non-del(5q. So here are patients that are RBC transfusion dependent with IPSS-R low-risk MDS that were non-del(5q were studied that were ineligible for or refractory to ESAs. And the primary endpoint that we were really looking at was RBC transfusion independence equal to or more than 8 weeks of duration. And I have to say that compared to the del(5q, the responses that we saw were modest, but we did see the primary endpoint was achieved in 26% of patients in the lenalidomide group and 2.5% of patients in the placebo group, respectively. And 90% of the patients that achieved this RBC transfusion independence responded within 16 weeks of treatment. So this is actually something that you could potentially see a pretty fast response to if they're responding. If not, you could always, try a next line of therapy or some other options. Some other secondary endpoints that were looked at in this trial were RBC transfusion independence for a longer duration, so more than or equal to 24 weeks, the duration of RBC transfusion independence, erythroid responses, quality of life measures, as well as safety. And the median duration of the RBC transfusion independence with lenalidomide was 30.9 weeks. I think this is actually so it says that, okay, maybe a smaller subset will respond, but they have a decent duration of response. And the transfusion reduction of more than or equal to 4 units of RBCs on the basis of a 112-day assessment was 21% in the lenalidomide group compared to 0% in the placebo group. And we did find also, as we do across the board in lower risk MDS, that the higher response rates were observed in patients with lower baseline endogenous EPO levels, so with less than or equal to 500 units per liter.
Thank you so much for that information. So, I mean, if I'm gathering everything that you've said, I mean, there's a couple key points that I took away from what you had for me. So, it sounds like originally, luspatercept was approved for these patients that had ring sideroblasts who'd failed ESA therapy. But now that indication is broadened where it's also an option for patients that may be ring sideroblasts negative in the first line therapy. It also sounds like a lot of these patients may not respond to that initial starting dose of luspatercept. We really need to think about maybe up-titrating them if we're not seeing the response we want to see in the first few cycles. And then lastly, while maybe not something that we think about as regularly with some of these new options, lenalidomide is potentially, while being clearly an option for del(5q) MDS, it can also be an option for patients without del(5q) who have low-risk MDS and associated anemia. So thank you so much, Dr. Shastri. This is super helpful.
It's my pleasure, Dr. Kuykendall.
So thank you for joining us for this Phone a Friend program. Please remember to take the post-test and fill out the CME evaluation. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. You can view other low-risk MDS Phone a Friend episodes on the series landing page.